Good morning. It's 7:30 and time to start our grand rounds. So welcome to Pediatric Grand Rounds. Please mute your devices when you join. The code for the CMA credit is in the chat box, and we'll keep repeating it every 10-15 minutes. So just look at the chat box for your CME code. I'm going to hand this over to Dr. Elaine Maldonado, who is going to introduce this morning's Grand Round speaker. Dr. Maldonado.
Thank you, Dr. Kamat. Good morning, everyone. I will try to keep this brief. It was a little bit difficult going through all of Ryan's accolades and trying to keep this brief, but we will do so in the interest of time. So Dr. Coleman obtained his medical degree with a distinction in research right here in San Antonio. He completed his pediatric residency and critical care fellowship at Baylor College of Medicine, where he was also asked to serve as the chief fellow. He currently holds appointments in the pediatric department, divisions of critical care and pulmonary medicine. And he also has an appointment in the Center for Medical Ethics and Health Policy. He is also the medical director of the RV Failure Program and clinical quality lead for ECMO at TCH. In addition, he is one of the authors of the upcoming scientific statement from the American Heart Association regarding pulmonary hypertension and congenital heart disease, which is coming in publication in 2023. And he's here today to talk about pulmonary hypertension. So welcome, Dr. Coleman. It's such a treat to have you here from Houston.
So thanks very much, Elaine. It's fantastic to be back here in San Antonio after going to medical school here and having the opportunity to work with so many of the great faculty here. So I really appreciate the opportunity to be here today to talk a little bit about pediatric pulmonary hypertension and where we are now. I heard that Dr. Reddy spoke last week about the right ventricle, so it's kind of fun to follow that with pulmonary hypertension. So we'll go ahead and get started. In terms of disclosures, I have no relevant financial disclosures to this. I will say, though, that talking about drugs to treat pediatric pulmonary hypertension, most of these are off-label uses of drugs approved to treat adult pulmonary hypertension. So that is just a little caveat. The roadmap for today. So I'm going to go through a little bit about the definitions of pulmonary hypertension and what exactly it is or is not, a little bit about the epidemiology and the prognosis for these patients, how we evaluate them, where therapies are now from a medication standpoint, and then moving into what happens when the medications don't work and how do we make decisions for treating those patients. And then a couple of slides at the very end just about sort of the future and where I think we may be headed. So in terms of definitions, to get started, what is pulmonary hypertension? And so I think the better way to think of it always is as pulmonary vascular disease. The pulmonary hypertension is a result of the disorders of the blood vessels. And so when you look at these children's blood vessels, you can find usually one of sort of three different things happening. So you can either see significant medial hyperplasia in these blood vessels. You can see intimal proliferation or the formation of plexiform lesions. It's not well understood right now why these things happen, but these are certainly the hallmarks of pulmonary vascular disease, which then leads to elevations in pulmonary pressures, and that ultimately can lead to RV dysfunction. And then sort of the final common pathway for all of these children is right ventricular failure. So this is a really nice paper that was published back in 2011, but it looks at pulmonary vascular disease in more detail. And if you look at the histology on the, I believe it should be on your left-hand side of the screen, you can see these actual plexiform lesions that have been dissected with laser-assisted dissection out of these vessels. And there's significant vascular abnormalities throughout the lung parenchyma in these children. Or adults who are affected with pulmonary hypertension. And then you can see sort of over time as things evolve, the disease only gets worse. You see abnormalities of the lymph tissue. This is particularly important when we're looking at diseases like pulmonary veno-occlusive disease, one of the hallmarks is that you see hilar lymphadenopathy in these patients. And so we know that there's a significant inflammatory component to part of this as well. But again, all of this is still not well understood. The other interesting thing about pulmonary hypertension is that it can also happen in the setting of other diseases. So, for example, in pediatrics, specifically our neonates, congenital diaphragmatic hernia. And you can see here again with these stains, the thickened vessel walls. You can see the smooth muscle proliferation here in green. And then when you look at sort of a normal blood vessel as compared to a blood vessel in a patient with congenital diaphragmatic hernia, you can see that we have significant vascular abnormalities in these patients. In terms of defining pulmonary hypertension, so in 2019, it really became more common in 2020. The definition actually changed for pulmonary hypertension. Traditionally, it was always taught as a mean pulmonary artery pressure greater than 25, but in 2020, it became greater than 20. And this is significant because obviously it increases the number of patients who can be diagnosed and affected by pulmonary hypertension. And I think it also gets to the point that we don't exactly know how much is too much. And so we're learning new things as we continue to take care of these patients. There's certain caveats when you're diagnosing pulmonary hypertension. For it to be a true precapillary, meaning arterial pulmonary hypertension, you need to have a normal wedge pressure, so meaning that there's no evidence of left-sided cardiac disease, and so a wedge less than 15, and then a calculated pulmonary vascular resistance. In pediatrics, it's always an indexed PVR, so a PVRI greater than 3. I'm not going to get into too much about post-capillary pulmonary hypertension today, just because that's another few talks in and of itself. And we're going to focus mainly just on the precapillary pulmonary hypertension today. Some other sort of key definitions that I think are important in pediatrics in particular. Obviously, Eisenmenger syndrome is one that's talked about a lot. And this is when patients with long-standing pulmonary hypertension ultimately reverse their cardiac shunts, and they become suprasystemic in terms of their pulmonary vascular resistance and pulmonary arterial pressures. And so they are persistently blue. So these are patients who, for example, maybe a late diagnosis VSD, a long-standing PDA. And so these patients will have saturations in the 70s to 80s and be perfectly fine. Patients who convert to Eisenmenger syndrome, where they maintain their right ventricular function despite these pulmonary arterial pressures, actually tend to do better in the long run, even in terms of survival, than patients who undergo lung transplant or are treated more aggressively. It's very interesting, and it's another patient population we don't know too much about. And then for pediatrics, again, looking at the single ventricle patients, these patients also can be obviously significantly affected by any alterations in their pulmonary vascular pressures, because they're completely dependent on passive pulmonary blood flow. And for those patients, we drop the definition to make it even easier in some ways to diagnose them with pulmonary hypertension. And we look for only a transpulmonary gradient greater than 6. And so in most patients, it's greater than 15 to 20. But for the single ventricle patients, we drop it lower because we know how detrimental elevated pulmonary pressures can be for them. In terms of how we classify pulmonary hypertension, the WHO has it broken up into really 5 main categories. For pediatrics, really group 1, which is the pulmonary arterial hypertension. These are the patients with associated congenital heart disease. These are the patients with mutations that are known to cause pulmonary hypertension. So, for example, we have taken care of a mutual patient between the cardiology group here and my group in Houston who had a SOX17 mutation causing his pulmonary hypertension. And so he recently underwent lung transplant and is doing quite well. But those patients fall into WHO group 1 pulmonary hypertension. The other big patient population that we take care of in pediatrics is group 3 pulmonary hypertension. So these is pulmonary hypertension secondary to lung disease. So this is where the patients with bronchopulmonary dysplasia fall into, patients with congenital diaphragmatic hernia fall into, patients with severe chronic obstructive sleep apnea can fall into group 3. And so really in peds, group 1 and group 3 are our main patients that we take care of. In adults, actually, it's group 2, pulmonary hypertension due to left heart disease. This comes a lot from adults who have either mitral valve disease or myocardial infarction resulting in left ventricular dysfunction. But thankfully in peds, we don't have to deal with that as often. There are other classification schemes out there. I put this up mainly just to show that people can really go all in terms of breaking up the classification schemes. But in general, the WHO scheme is the most important one and the one that we most commonly use. All right, so how do these patients do? How do we diagnose them? What does PH look like? And so this is a really nice infographic that was done by the Europeans when they published their most recent guidelines in 2022. And so when we look at infant pulmonary hypertension, so these are the patients with PPHN in the immediate neonatal period. These are patients that have things like pulmonary vein stenosis, developmental lung diseases, bronchopulmonary dysplasia, the really severe kids that have alveolar capillary dysplasia when they're born can have really wicked pulmonary hypertension that really is not treatable. And then as we move into sort of the child category, you can see that the reasons for their disease changes over time. And so then we start seeing the pulmonary arterial hypertension associated with congenital heart disease. We see the idiopathic pulmonary arterial hypertension, so those with BMPR2, SOC17 mutations, kids with trisomy 21 who have longstanding underlying congenital heart disease. This is where we start really seeing these patients come out and become the more commonly seen ones. I think the thing that makes pediatric pulmonary hypertension in general really challenging is that whereas in adults, you can usually narrow it down to, like I said, a left heart lesion. In kids, we have to really factor in a lot of multiple conditions that can really cause this. So you take a child who has, for example, underlying trisomy 21, and there's some data that some of the vascular growth factors on the 21st chromosome can really cause underlying significant arterial disease. You combine that with obstructive sleep apnea as a result of their macroglossia, and that can further add to their pulmonary vascular disease burden. And then you add in the AV canal or the PDA or the VSD, and suddenly you're fighting multiple factors when you're trying to control their disease. Same with congenital diaphragmatic hernia, for example. You take these patients that have a small left lung, you throw that in with maybe an underlying VSD or a PDA. These patients can have small left-sided structures just because as their heart's trying to develop, they've got a lot of ballop in their chest. And so then you add in a small arch, a small mitral valve, and again, it can only complicate the pulmonary hypertension that you're trying to manage. So in terms of the frequency with which we see it, who makes up these patients, so these are data from the top registry. They were published in 2012. Top 2 is currently being analyzed right now. And so when we look at patients that have it, it's a very rare disease, thankfully. And then when we look at who makes it up, you can see that again, sort of the most common causes are on the arterial side of the circulation. And then when you break those patients down, you have the idiopathic pulmonary arterial hypertension, so the genetic mutation patients. APAH-CHD is the pulmonary arterial hypertension associated with congenital heart disease. And those two are the big bulk of who we see and who we treat. So these are great data from the Netherlands. Because they have a centralized health system, they're able to get a much cleaner data set. And you can see here again, sort of a similar breakdown. Thankfully, most of the disease is on the arterial side, which is great because our drugs work much better for treating arterial hypertension than they do venous. And again, the big populations are idiopathic and then those associated with congenital heart disease. And so when you look at the annual incident cases per million, you can see again that thankfully it's relatively rare. And then as you break it down, the congenital heart disease is more common than the idiopathic, which again is a good thing because we can do something about congenital heart disease and try to make that better, which in turn will increase the health of the pulmonary vascular bed. Survival data, right? So what happens? I know that when I first started fellowship, I used to hate taking care of patients with pulmonary hypertension because it felt like they all died. It was a disease that I was very scared of, which is in the end why I ended up wanting to take care of these patients. So their survival curves are not great. And so you can see the Kaplan-Meier for progressive or idiopathic pulmonary hypertension. And sort of when you start getting to the 50th percent, survival is roughly 7 years after diagnosis. So it's not a lot of time to try to make things better. When we compare those patients to those with, say, congenital heart disease, which again are a big bulk of pediatric patients, those with congenital heart disease tend to do a little bit better, which makes sense because we can, again, do something about their congenital heart disease to try to make the underlying problem go away. When we look at risk profiles for these patients, so when a new patient presents to us, how do we decide how aggressive we're going to be up front with their therapy, or how do we counsel these families? These are sort of the things that we can look at. So do they present already showing signs of RV failure or not? The 6-MWT is a 6-minute walk test. So this is a commonly used test for either patients with congestive heart failure or patients with pulmonary hypertension. And so we see how far they can walk in 6 minutes. And obviously, the further you can walk, the better shape you're in, the lower risk you're at in terms of presentation. The other one that really makes me nervous in a new patient is the presence of a pericardial effusion. If a new patient walks in and they've got a pericardial effusion, you need to be very worried and very concerned. This is a simpler tool that was recently developed, again, looking at these data. And in the end, it's how far can they walk? How disabled are they from an overall functional standpoint? And then if we draw a BNP or an NT-proBNP, so brain natriuretic peptide, how elevated is it? And again, these are fairly simple things you can do to get a good idea of just how sick is this patient and how worried do I need to be about what's going to happen. So how does PH present? How do you find these patients that are relatively rare but can be incredibly ill if you miss it? So common signs of pulmonary hypertension, the big ones that we see, particularly in pediatric patients, are some clubbing. These patients will get cyanotic with exercise. And then on exam, you'll hear their tricuspid regurgitation systolic murmur. Those are the most common things that we see usually when these patients present. Obviously, there are other things that these patients can have, depending on how far down the line they are. You can have things like hepatomegaly, ascites, peripheral edema, but if you get to that point, they're pretty ill at presentation. Symptoms of PH, the big one in pediatrics is decreasing exercise tolerance. So parents will often tell us that they notice that their child used to run and play for hours, and now after 10 to 15 minutes, they'll see them sitting down. Older teenagers will tell us this. They used to be star baseball players, and now they can barely run to first base, and they don't understand what's happening. And then syncope. Syncope is a huge red flag and something that needs to be taken very seriously whenever it presents, because that is the other big common presenting sign of pulmonary hypertension. And so we looked at our patient population at TCH a few years ago and took a cohort of 29 patients from a 5-year period to see how they presented. And if you look here, the average time between their onset of symptoms, most commonly syncope and worsening exercise tolerance, to actually being diagnosed was almost 10 months. Some of these patients would come in, have a syncopal episode, they would get MRIs, they would get EEGs, all sorts of testing done, but nobody ever got a chest x-ray. And then once somebody finally got a chest x-ray and saw the cardiomegaly, then we started going down the line of diagnosing their pulmonary hypertension. And so again, 10 months from initial presentation to diagnosis is a long time to wait for the right thing. How do we evaluate these patients when they come in? So what does a standard pH evaluation look like? Again, this is a little bit of a busy slide, but it shows kind of all the things we do to really get to the bottom of this diagnosis. The big things, though, that we really kind of count on are really basic things like a chest X-ray, an EKG, and then an echo. So these are two pictures from a patient who was a new diagnosis to us. When she came in, she was a teenager. If you look at the chest X-ray, you can see the significant cardiomegaly, and the thing that stands out in these patients is this prominent knob right here, which is their PA that's pushing up. And so if you ever see this combination in a patient with syncope, please think about pulmonary hypertension. And then when we got a CT chest, you can see this big pulmonary artery here that's bigger than the aorta. And again, this is sort of a classic sign of significant pulmonary vascular disease. And if you see a PA that's larger than an aorta, you've got a challenging situation on your hands. These are the common EKG findings. Again, looking for evidence of right ventricular hypertrophy and RV strain are sort of the big warning signs. We then move to echo. So there's lots of views you can get. I put this up here mainly to show that there's some great data out there for people who really are interested in looking at how we diagnose it. There's lots of ways to do it. The big one, though, that sort of is our commonly followed indicator of pulmonary hypertension is the tricuspid regurgitation jet. So this is a very easy to find on echo parameter that we use. We can use this to then estimate the RV pressure, which can then ultimately give us an estimate of the pulmonary arterial pressure. We do it with the modified Bernoulli equation, but you really need a good echo picture in order to do this. And so these are some pictures from a couple of different patients that we've taken care of over time. And you can see these really nice clean envelopes that we can use to make this diagnosis. Once we see evidence of pulmonary hypertension by echo, by chest X-ray, by EKG, we then move on to cardiac catheterization. This is always a challenging population. If there's interventional cardiologists or the cardiac surgeons listening to this, they all know how nervous everyone gets when you take a patient with pulmonary hypertension to the cath lab. These patients are very challenging to put to sleep. Their anesthetic risk is quite significant. But cardiac cath is a mainstay of managing and following these patients over time. And then a tool that we've become to started using more and more in pulmonary hypertension is actually cardiac MRI. With cardiac MRI, you can actually really nicely assess the right ventricle, get adequate assessments of ventricular function, pulmonary blood flow. You could see the myocardium in more detail and look for evidence of myocardial damage. Through using Cine CMR clips, we can really look at global RV volumes, muscle mass, pump function, and there's some great data. Again, these are adult data. We haven't really seen great data sets come out yet in pediatrics, correlating actually MRI with 6-minute walk test, functional class, and ultimately cath pressures. And so if we can get to the point where something like a non-invasive cardiac MRI can give us reliable estimated intracardiac pressures, that would be a huge game changer in terms of risk these patients first face. Blood flow is another element we can get from cardiac MRI. These are some great pictures where you can actually see blood flow patterns. And one of the interesting things you can see here on the left is actually eddies of flow that you can have happen in the setting of significant pulmonary vascular disease where it's hard for blood to get out. And so it ends up swirling in the PA, which can then lead to potential for thrombus formation. The other thing that's important is differential lung perfusion. And so again, say you've got a patient with pulmonary vein stenosis on one side and you're trying to figure out, do I go after this pulmonary vein disease or do I sort of sacrifice the vein? One of the ways you can make that decision is by looking at pulmonary blood flow. And if they're already sending a huge amount of pulmonary blood flow to the unaffected lung, it may not be worth the risk of going after that pulmonary vein. And then the myocardium assessment is really important in pulmonary vascular disease because if we see a patient that's got significant myocardial inflammation or fibrosis, it gives you a sense of how long-standing their pulmonary hypertension is. And then when I think about how do I manage them long-term, when we're talking about transplant options, if they have a heart that's showing significant disease already, do I need to consider heart-lung transplant versus heart transplant? So it's really a great tool that we're becoming more and more facile with. All right, so how do we treat pulmonary hypertension? There are kind of 6 main classes of drugs or families, I should say, that we use, but really for treating the pulmonary vascular disease, there's only 3 that we can really go after on a somewhat easy basis. Um, Other things we try to do are maybe control the inflammation. We can do things like anticoagulation, though that's becoming less in vogue today, particularly in pediatric patients. This is a slide courtesy of Shelley Kim. She was one of the first pulmonary hypertension pharmacists that I worked with, and who was one of my main teachers that I'm always eternally grateful for. And so when you look at kind of the drugs that we use to treat pulmonary hypertension, you can see that these are new drugs. We're just now learning how to do these things, how to manage this disease, and starting to see the effects. The most recently developed drug is Selexipag that we're using more and more commonly. That's a PO prostacyclin agonist that we're now starting to figure out which patients we can use this in. It only came out in 2015 is sort of when it was approved, but we didn't really start using it in pediatric patients until 2017, 2018. So this is a new disease where every day things are changing. Even drugs that we used in fellowship when I was a fellow, which was not that long ago, we don't really use the same or in the same way now that I'm out. These drugs tend to fall in sort of 3 main pathways that we go after. There's the nitric oxide pathway. This is where sildenafil comes in. There's the prostacyclin pathway, so drugs like epoprostenil or treprostinil. So those are Remodulin and Velitri fall in here. Selexipag falls in the prostacyclin pathway. And then when we look at the endothelin pathway, we have drugs like bosentan and ambrisentan. For example, in the setting of congenital heart disease, drugs like bosentan are particularly helpful because endothelin-1 is one of the main mediators of disease in patients with pulmonary hypertension associated with congenital heart disease. Those patients that have large shunts, so like a large VSD or a large PDA where there's a lot of shear, tend to release endothelin. And so we use these drugs preferentially in those patient populations. Not sure what's happening. Okay. So I'm sorry if the slides are flipping back and forth, guys. I'm not sure what it's doing. Yeah, I'm not sure what all of a sudden just happened. Oh, maybe it stopped.
Okay.
Okay, maybe it stopped. We're good.
Okay.
Sorry about that, guys. I'm not sure why it just did that. In terms of how we treat pulmonary hypertension, sort of our general approach for going after these patients. The first line therapy that we tend to use is sildenafil or tadalafil. These drugs are very well tolerated with minimal side effects. They're fairly accessible and easy to find. And so that tends to be where we go after our therapies first. Bosentan and ambrisentan are second line therapies. We tend to use these as our second line in general. Like I said, I'd use them first line for congenital heart patients, but there's the potential for hepatic toxicity with bosentan. We have to monitor liver function labs on a monthly basis because of the potential for hepatic toxicity. And then for patients, for females of childbearing potential, so this is even when you start talking about females as young as 10, 11, you have to monitor pregnancy tests. They need to be on birth control once they enter menarche because there's significant teratogenicity associated with ERAs. And so again, they're really intensive therapies that we try to use only when necessary. Prostacyclins are our third line therapy, again, because these are even more intensive and invasive. We usually, my general approach is to start with Velitri or epoprostenol. It's a short-acting prostacyclin. So as we're initiating it, you can rapidly titrate up and down as you need. But because it has a very short half-life, there's a lot of ICU implications for access and things that you need to watch when you're using it. You need to always have, for example, a backup line because the half-life is about 3 minutes. So you need to be able to move the infusion quickly. Once we're on a stable dose, we then transition to Remodulin, which is a longer acting prostacyclin with a half-life of 3 to 4 hours. But to send patients home on these drugs, there's significant coordination that's needed. There's a lot of teaching that goes into it. And so it's not a simple thing to do. We're gaining more experience with using PO selexipag. And now we're starting to try to initiate it before we use the IV or subcutaneous infusions. But again, we're still trying to figure out who the right patients are for this drug. And so I don't know that we've got it down just yet. All right, but what happens when the drugs don't work? I think that's when it becomes really challenging. So when the RV starts becoming more and more pressure loaded, things start changing, and not always for the better. And so as the pressure load increases on the right ventricle, if you kind of think back to the embryologic origins and how the RV is formed, it's not meant for high pressure circulation. So it only has 2 muscle layers instead of 3 muscle layers. When it squeezes, it doesn't have that concentric strong squeeze that the LV does. Rather, it squeezes in almost a peristaltic fashion. And so as you increase its pressure load, it becomes more and more challenging for the RV. And so initially, you'll see it kind of remodel and hypertrophy, but over time, you can really see it dilate and become less and less effective. And so this is an example from 2 autopsy specimens of patients with pulmonary vascular disease. The top shows adaptive remodeling. So this is what, for example, a patient with Eisenmenger would look like. And you can see that the RV stays nice and thick and concentric versus a maladaptive right ventricular hypertrophy ventricle down here, where you see it sort of just falling apart and dilating up. So things that we can do for these patients. So atrial septostomy was sort of the mainstay in terms of what people thought the right thing to do for these patients was. So these are some data from the Columbia group where they show what happened to their patients where they put atrial septostomies in patients presenting with right heart failure. You can see that for about half of them, they had some improved right heart failure symptoms, but for the other half, they still progressed on with disease. And the reason for that is when you look at how an atrial septostomy works in the setting of pulmonary vascular disease, it's a volume unloading shunt. It's not a pressure unloading shunt. And so when the RV fails, it fails because of pressure load, not volume load. And so in atrial septostomy, for the RV to decompress up at the atrial level, right, you have to have a really high right ventricular and diastolic pressure that then translates up into an elevated right atrial pressure that then is able to overcome your left atrial pressure. And so depending on how severe the pulmonary hypertension is and how abnormal your interventricular interactions are, sometimes the septostomy is not actually going to work in these patients. And so other options are the pot shunt. This is becoming more and more in vogue for medically refractory pulmonary hypertension. And so the pot shunt initially was developed back in the kind of mid-1940s. And so the first operation was done for POTS in 1946. It was done in a 20-month-old female with tetralogy of Fallot who at age 21 months only weighed 18 pounds and presented with a hemoglobin of 18.6. So this was a deeply cyanotic patient. And so the pot shunt was done, and I'll show you pictures of it here, where the aorta and the pulmonary artery were directly anastomosed together. And so this allowed for the suprasystemic pulmonary arterial pressures to pop off to the aorta. And so this relationship allowed for the right ventricle to be able to sort of restore some of its function because it suddenly had a pressure pop off. This is the original paper that was published in 1946 in JAMA, where you can see the illustrations that were done to show how to do this operation. This is just for fun, but this was published in the Chicago Daily Tribune in 1960, where They show Dr. Potts with his first patient. And I think this was really great because in part, when they interview the mom of this patient, she talks about how her daughter was deeply cyanotic and subject to many attacks of syncope or swooning, including when Dr. Potts examined her, but mom said, "Don't worry about it. It was nothing unusual that she passed out." So obviously, you can tell just how sick and fragile these patients were when they went to do these operations, and how desensitized, unfortunately, the mom had become to her daughter passing out. So again, we're using the POTS shunt more and more. So these are some of our data that we put together that were published in JACC in 2021. This is from an international POTS registry where people from all over the world contributed patients with pulmonary hypertension who underwent either a surgical pulmonary to systemic shunt creation or had, for example, a stent put in their ductus arteriosus, which would create the same type of physiology. And you can see sort of the survival over time. So it's not necessarily great, and that sort of at 5 years, you're about 65-ish% survival. But I think the big thing is that this is a much less morbid procedure than, say, a lung transplant. When we look at how these patients did, pre-procedure, you can see that a lot of these patients were very deconditioned. They had a low functional class status. Most of them were in the 3 and 4 range. But after their POTS shunt and restoration of their RV function, you can see that their functional class markedly improved. They went from 3s and 4s to 1s and 2s, meaning they could live their lives without significant impairment. Their BNPs dropped, their 6-minute walk distance increased, and importantly, a lot of them were able to wean off of their prostacyclin infusions. And so for those of you who have ever taken care of a patient on subcutaneous or continuous IV Remodulin, those types of infusions make it where you can't swim, for example. They're very painful when you have to rotate sites. And so being able to get off of those infusions really improves quality of life for these patients. If you remember this Kaplan-Meier curve, and then we move to lung transplant and pulmonary hypertension. So this is from a review published in 2021. You look at the pulmonary hypertension patients. So the panel on your left-hand side is sort of all-comer lung transplant. When you look at sort of the 5-year mark, which is where we are right now with our pulmonary to systemic or POTS shunt patients, you can see that initially for pulmonary hypertension not IPAH, so that's pulmonary hypertension not due to genetic mutation, your 5-year survival is under the 50% mark. When you look at it for those patients with genetically mediated pulmonary hypertension at the 5-year mark, you see that it's roughly sort of in the 60th percentile or 60% survival, which is about what a POTS shunt is. This graph on the right is survival if you survive the first year after transplant, which is why the curves move up. And you can see that the numbers go a little bit higher, and it's maybe closer to 80% at 5 years, which may be a little bit better than our POTS shunt data, though the caveat with the POTS shunt data is we were placing it in all sorts of patients in the registry data, including those that already had severe RV dysfunction. What we're learning now is that may not have been the right choice. And so I think you will see this the data for POTS shunt evolving over time as we get more experience with the procedure. Ductal stenting is an option. So these are some patients where we've used the ductal stent as an option for severe pulmonary hypertension in some patients at TCH. You can see that we've done it in patients as young as 1 month up to a 14-year-old patient who had initially her PDA closed in the setting of congenital diaphragmatic hernia. And then ultimately, one of our interventional cardiologists was able to get a wire back across the ductal closure device, crack that device, and place a stent. And you can see she had a mean PA pressure of 114 when he did that, with a PVR that calculated only at 16, which in part was due to cardiac index. But it's an option for these patients that if you can do it in the cath lab, obviously it's less morbidity than needing a thoracotomy or sternotomy to place the shunt. So it's an option. The other thing that we've done a few times at TCH, I still don't know how I feel about it, but it's an option, is actually creation of a ventricular septal defect to try to pressure unload that RV. So we've done it in 4 patients at TCH. You can see the patients in which we did it. Sometimes it was a salvage therapy for the first one. For the other patients in which we did it, it was sort of a destination therapy, meaning that these patients weren't lung transplant candidates. And so creation of their ventricular septal defect is their final palliation. And so we're hoping that they'll turn into an Eisenmenger type patient and how they'll live their life. And you can see sort of their PA pressures when these were done. This is a screen grab from the cath lab when this was done. And so you can see a stent here across the ventricular septum with the wire going across in this patient. So the other sort of big thing that we do for these patients is central ECMO as a bridge to transplant. So when the RV fails, you're talking about transplant, and you've got to somehow figure out how to get these patients to survive. Traditional ECMO is not always a great option when you've got a failing right ventricle. And so we have done this now in 6 patients, one of whom was a patient with cystic fibrosis, so didn't really have significant pulmonary vascular disease per se. But in the patients where we did central ECMO as a bridge to transplant, you can see how we place their cannulas. And so I'll show you some illustrations of that in just a second. But we are able to get these patients off to their lungs. So these are some pictures from a publication that we've got currently submitted describing our experience. And so for VA central ECMO cannulation in this strategy, the venous line was placed into the main PA to try to still allow the RV to load and squeeze, but then pressure unload it so it stayed conditioned, with then your arterial inflow being placed into the aorta. When we did it for central VV ECMO, you can see that the venous drainage was placed in the right atrium, and then the inflow into the aorta. This was done using Berlin cannulae. And so we were able to tunnel them out of the chest, subsequently close the chest, and then have these patients up and rehabbing. And I'll show you some pictures of that in just a second. We also did this in a patient who had a history of detransposition of the great arteries, who then underwent a switch and had a LeCompte where the PA was brought forward. And so even in those patients, we were able to use a similar approach to bridge him to lung transplant. He stayed on this configuration of VA ECMO for 18 days before we were able to get him transplanted. These are pictures of our first patient in whom we did central VA ECMO as a bridge to transplant, and you can see that he wasn't particularly always happy about doing his physical therapy, but he was awake, extubated up. You can see his cannula are wrapped down here. This is Amy, one of our fantastic physical therapists, who we're eternally grateful for helping us do this. And you can see him awake, rehabbing, and doing his job while he waited for his lung transplant. So these are some data where we looked at mathematical modeling of these shunts. And you can see here that when we compare all these different options that I just showed you for treating these patients with refractory pulmonary hypertension, it really looks like the POT shunt, or a pulmonary to systemic shunt creation, is the best option. You can see that it brings down their PA pressure the best and really improves their systemic cardiac output. And so these data from computer models based on real patients, I think, support that now we're moving more to the POT shunt as our kind of go-to therapy for some of these patients. And we're talking about it earlier and earlier in their course, meaning do we consider a POTS shunt or pulmonary to systemic shunt creation when we start thinking prostacyclins? Is it that the time to do it? So it's really sort of the unknown territory and where we're headed. And so for the last couple of minutes, what does the future hold for pulmonary hypertension? Honestly, I'm not really sure. We're finally gaining more and more experience with these drugs. If you remember from the drug development slide I showed you, We're just now getting into the 15, 20-year mark with some of these drugs. Some we've only had experience for 5 to 10 years. And so I think we're still better learning how to use them, but all of those drugs only treat the downstream effects of pulmonary vascular disease. They're all vasodilators. They don't actually treat the mechanism of the disease. And so I hope that we start developing drugs that target the mechanism of the disease. And I'll show you a slide in just a second of some of the new drugs being developed. We're still really trying to figure out what to do when medications don't work. And so there's a group now through the American Thoracic Society where we're sitting down trying to iron these things out and come up with at least the ability to do some randomized trials to look at this. We're also forming a network called PDRV. And so this is going to be for really, again, trying to develop groups aimed at treating the right ventricle, creating the randomized trials that we need to really answer these questions in more appropriate detail. We're still working to figure out when the right time is to refer patients for transplant, for surgical palliation. And like I said, I hope we get some drugs that actually treat the mechanism instead of the downstream effects, because if we're only treating the downstream effects, we're not actually overcoming the disease itself. This is a busy slide, and I know it presents small, but I mainly put it up just to show that there are drugs being developed that are in various animal trial stages right now. Some of them are looking more at mechanisms, but then unfortunately some are still just vasodilators. So who knows what it's going to look like. You know, I have a sneaking suspicion that in 5 years I'm going to be prescribing different drugs than I'm even prescribing today for patients with pulmonary hypertension. But in the end, you know, I think that there are great options for these patients. I put this up because if you see the patient on the left, this was a patient with pulmonary veno-occlusive disease who we were able to manage with drug therapy till she underwent her transplant. And then the patient on the right who made me that super cool drawing of lungs that I have in my office today is a patient with idiopathic pulmonary arterial hypertension. And so we're really working right at the end of the day to figure out how to continue to improve outcomes for these patients, to do what we can to make things better for them in the long term, and really get at a disease that causes significant morbidity and mortality. And with that, I put up my email address. I'm always happy to chat about pulmonary vascular disease, or if any of you are interested in spending some time with us or rotating with us, we'd love to have you, and I'm happy to answer any questions you may have. And thanks again to Dr. Maldonado and Dr. Kamat for the opportunity to come and speak to you guys today.
Thank you, Dr. Coleman, for that fascinating presentation on pulmonary hypertension and educating us on pulmonary hypertension. I see Dr. Perlman has already raised his hand. Can you ask your question, please?
Okay. Yeah, can you explain something kind of basic to me? I understand why these kids would present with syncope because there's less blood flow through the lungs and decreased preload to the left heart. But like, why would they get cyanotic? Is there some kind of intrapulmonary shunt or something? Like, how does that happen?
Sure, good question. And so I think one of the things that tends to happen in these patients sometimes is they lose, sometimes it's a reflection of poor cardiac output and poor pulmonary blood flow, where they become cyanotic. And so sometimes I think it's a reflection of their entire cardiac output state. The other things that we can see with them too, sometimes it's a manifestation of an undiagnosed congenital heart lesion. We've had patients who were found to have a, one in particular I can think of was a missed PDA, that she was becoming more and more cyanotic. People didn't know why. Ultimately turned in, we found a ductus that had been missed for a long time. So I think it's a reflection of both of those two things.
I think Dr. Abarbanel has a question.
Okay.
Thanks, Dr. Maldonado. Thank you, Dr. Coleman, for coming. Can you hear me okay?
Yes, sir.
Hey, I really appreciate your talk because, you know, I came from WashU to here, and these are some of the questions we really struggled with. And I'm interested in your thoughts on transplantation after POTS, because we seem to think as we were going further along down the POTS palliation, perhaps POTS survival was better than lung transplantation overall, since the lung transplant survival is not as good as, say, the heart transplant. I was just wondering what your institutional experience has been and where your leaning is towards POTS transplantation as the final step versus lung transplantation. And, I looked at the UNOS numbers recently, and the number of lung transplants has gone down drastically because of Trikafta and the lack of CF. So I'm not sure how much lung transplantation is even going on in Texas. So I'd also be interested in your perspective on that as well, too, please.
Sure. So great questions. And speaking of WashU, so Dr. Mark Grady at WashU is one of my mentors, and he really has pioneered sort of the POTS shunt experience in the United States. And so in terms of transplant and POTS shunt, I think we're still learning about how best to do those patients. So, in talking with Dr. Ektasadi and Dr. Grady at WashU, looking at what we've done at TCH. So in general, for idiopathic pulmonary arterial hypertension, if you can get to these patients when their RV function is still in the mild to moderately depressed patients, I think those are the patients where doing a POTS shunt rather than going straight to transplant is the right move. Those are the patients now where we're looking to do more and more POTS shunt placements. We've done it in a patient status post actually transposition and switch at TCH. He's gotten his POTS now, and his RV function is normalized, and he's doing great. And we probably will never transplant him. The original transplants that were done following POTS shunts, and you may have been a part of those when you were at WashU, were very bloody, very unpleasant affairs. With the original shunts that were placed via thoracotomy, those were really tough for the surgeons to get to and control, and they caused a lot of bleeding. So now I know that this approach at WashU has switched to where they do it from a sternotomy up front with a conduit, so it's easier to control. The group at Columbia is doing that. At TCH, when we do our next POTS, it'll be sternotomy with a valved conduit so that it's easier to get to and control at the time of transplant. When we did a transplant in a patient who, I mentioned her as the patient, she was a teenager who had a history of congenital diaphragmatic hernia, status post-repair, who then had her PDA closed with a device. Then the PDA cracked and reopened. When she went for her lung transplant, it was, again, a very bloody, very prolonged affair. Talking to Jeff Heinley, who did her transplant at TCH, he told me that he was never going to transplant a patient after a POTS shunt again because it was such a miserable experience. Because she was, again, the bleeding, he thinks that there's a lot of abnormal vascular maybe connections that form within the lungs, and so they tend to just ooze and are difficult to control. And so that being said, he told me now that if we do it with a valved conduit, he'll still consider transplanting them. So, I think it's going to be valved conduit POTS to then potential transplant versus not, depending on what the family wants, as opposed to going straight to transplant if the RV function hasn't tanked. If you lose your RV function, though, the survival data are not great for a POTS shunt in the setting of severe RV dysfunction, or like a POTS coming off of ECMO because you fell apart. And so there we're still talking about transplant. At TCH, we tend to be, even in those patients, a lung transplant only, hoping that the heart will recover. If you go to Stanford, they'll do a combined heart-lung transplant. So I don't know that we've figured out exactly that part of things yet, but we're doing a fair amount of transplants. So for pulmonary vascular disease, so the last 3 transplants we've done at TCH for lungs have been the patient I just showed you on the left with pulmonary veno-occlusive disease. We've done another pulmonary veno-occlusive disease recently who was on ECMO as a bridge to transplant. We did a CFer who had been on she was interesting. She was a 4-year-old patient with cystic fibrosis who got really sick with a MSSA pneumonia following a viral infection, and then just her lungs never recovered. We had her on VV ECMO, traditional VV ECMO through the right neck with an Avalon cannula for 207 days waiting for her lung transplant. We recently transplanted her. So I agree, the lung transplant game now is all pulmonary vascular disease for the most part and not cystic fibrosis anymore. So we're doing a fair amount of them, but it's for a completely different indication these days.
Yeah, thank you so much. I really look forward to meeting you tonight.
I'm looking forward to it as well.
Any other questions or comments for Dr. Coleman?
So, well, thank you everybody again. This was a real honor to be able to come back to San Antonio, where I got my start with Dr. Maldonado, Dr. Calhoun, sort of skipping class and hanging out too much with them. But again, thanks again for this great opportunity. I really, really appreciate it, and I look forward to hearing from you guys if there's anything I can do.
Thank you, Dr. Coleman. So we will conclude our grand rounds for this morning, and thanks everyone. Have a great day.
Thank you.
You close it out already.